So, I'd like to welcome you all to the July session of the Erie County Workforce Collaborative Training Series. Yay! The Erie County Department of Mental Health is so happy to be able to offer these trainings to the dedicated providers in our community. They're being offered to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we are so lucky to have Jillian Warner-Dombrowski, who is a MS, Master's CASAC, and a Ph.D. candidate, and the co-occurring disorders supervising counselor at Transitional Services, Inc., who will be talking about co-occurring disorders, prevalence, challenges, and strategies. I'm pleased to announce that the topic for August will be adapting to our new normal. Our presenters for that will be Esther Call and Ayana Lal, both LMHCs and clinical supervisors in the Counseling Services Program at Child and Family Services. They'll be discussing how to successfully transition out of the pandemic, hopefully it's actually over, sort of, and create new routines, all while developing a new normal for ourselves, our families, and the individuals we serve. They'll also address the residual effects of the pandemic on providers and explore strategies for healthy coping and management. That will be August 24th at noon. You can go to the Erie County Department of Mental Health website to register. I'll also be posting a link to the registration at the end of this session. So this is truly a community collaborative. We're looking for more volunteers to share expertise with our community of providers. If you're interested in doing a 1-hour presentation, please let me know. Also, if you have a particular topic that you'd like to see us cover and discuss in one of these sessions, let me know that too, and we'll try to find a presenter. My email address is amy.rockwood@erie.gov. This training will be recorded. If you are not okay with this being recorded, you can disconnect now. Excuse me, everyone is muted, so if you have questions, please put them in the chat box, and Kathleen Larson, who is from the Department of Mental Health as well, will be monitoring the chat for us during the session. At the end of this session, we will be asking you to complete a very brief evaluation. We hope you'll take a moment to fill this out so we can continue to improve. Thank you all for joining us today, and I'd like to now introduce Jillian Warner-Dombrowski for her presentation on co-occurring disorders, prevalence, challenges, and strategies. Thank you so much, Jillian, and it's all yours.
Hi, Amy. Thank you so much, Amy and Kathleen, for helping me and giving me this opportunity. I appreciate it. And welcome everybody to this training. Thank you for logging on, especially on a summer day when it's hard sometimes to focus on stuff if you're like me and have summer brain. So I am a co-occurring disorder supervising counselor right now at Transitional Services. I've been in the mental health field for 20 years and addiction field, specializing mostly in addiction throughout that time. I've worked in lots of different contexts with children, adolescents, with older people. I've worked in like foster care types of situations, outpatient at the administrative level. I'm also an adjunct faculty at UB in the counseling, school and educational psychology departments, and an adjunct faculty at Canisius College in the criminal justice and sociology departments. I initially started my career in law enforcement, so it's still very close to my heart, and I'm happy to have the opportunity to still teach in that area as well. So today I'm going to be presenting to you on co-occurring disorders. And before I start any class or before I start any presentations that I do, I usually like to talk to my audience a bit about one of my favorite quotes by Randy Pausch, who you may know from the last lecture series. He did a lecture that was very famous, wrote a book. He was a professor who was dying and wanted to record a lecture for his children to watch someday when they were older. And one of my favorite things he teaches us is that when there is an elephant in the room, introduce him. So I introduce my elephant to my audiences, which is my speech. And I just want to let you guys know that I have not been drinking before the presentation. I promise you. I am a 4-time survivor of head and neck cancer, and one of my treatment interventions required having 1/4 of my tongue removed. So that's why I sound this way. It doesn't usually affect much. You'll see there's some words I have a hard time pronouncing, and I usually try to work around it by using different phrasing. But if at any time you need clarification on something I've said, please put something in the chat and Kathleen will let me know. I'm very honest about it. I've been dealing with it for 12 years and it does not bother me if you need me to repeat something or say something in a different way. So that's my elephant. We can say hi to him. I haven't named him yet, but maybe I should, right? With all the speaking that I do in public. So something for me to think about or something to have my students do for me, maybe, right? But my presentation today is going to focus on co-occurring mental health disorders and substance use disorders, especially. That's my bias. I've spent a lot of time in my career working with that in adults. Again, I've spent the majority of my career working with adults. I will provide some information on adolescents and elderly populations. I know there may be people working in all different areas, so I thought it would be nice to hear some of those numbers too. We'll be talking about prevalence, some of the most common disorders that we see, challenges that can occur with assessment in this population, strategies for assessment, and best practices in service provision. So if you are not sure what co-occurring disorders are, like when I left the law enforcement field and came into the mental health field, no idea what co-occurring disorders were. And that was a long time ago, right? 20 some years ago. And back then, people used to refer to this as MICA. And some of you might remember that. And I believe it stood for mentally ill, chemically addicted, which always struck me as a little bit judgmental to label clients that way. So I'm happy to see that now we refer to it as co-occurring disorders. Some people in medical fields may refer to it as a comorbidity. So all of these are usually used interchangeably. And it refers to the presence of 2 or more mental health disorders or medical illnesses. So a lot of times people don't really think as much about these disorders unless you're in the mental health or substance use field. But I have run across some doctors who actually do diagnose a physical health disorder with a mental health or substance use disorder. So it's not just used in the mental health field. And in terms of the timing, it's really hard to know which one came first in most cases. Sometimes we may never know, sometimes our clients may never know, and in other instances, our clients can tell us exactly what happened first. Maybe they can tell us, you know, an activating event that kind of kicked their depression into gear, and they may remember the first time they picked up a substance to actually meditate some of those things that they felt. So it's always best to kind of have a conversation with your client about, you know, can you tell me a little bit about when your symptoms started or when you started noticing that? Can you tell me a bit about the first time you picked up a substance and the first time you engaged in using it regularly, right? And maybe that will help you, but maybe not. It's important to know that interactions between the 2 disorders will complicate each other, right? We're not just treating one or the other, we're treating both. And substance use affects mental health and vice versa. So we have that complexity of the interactions kind of taking things up, and sometimes I've had clients describe this to me as feeling like they were living in a storm or a tornado because everything, excuse me, ticked up all at once and they don't know where to start. So just keep that in mind, I guess, as we keep talking here. Some of the most common disorders that we encounter when we're doing COD work, and especially when I worked in addiction treatment settings, we saw a lot of the mental health disorders listed kind of working with substance use disorders to challenge our clients. Very common for depressive disorders, bipolar 1 disorder, post-traumatic stress, personality disorders, anxiety, ADHD, eating disorders. In the program I run, we have quite a few people diagnosed with schizophrenia or other types of psychotic disorders, and they're actively using or are just in the beginning phases of their recoveries. Many people report experiencing the symptoms of the disorder they may or may not be diagnosed with, and they are trying to medicate what they're experiencing symptom-wise with some of these substances that they end up using. So if you worked in an addiction treatment setting, you've probably seen all of these. Mental health setting, I'm sure you've seen all of these. But when I was in addiction treatment at the beginning of my career, all this mental health diagnosis was very, very new to me. So I didn't have a lot of experience with those. So what are the substances people are using to medicate themselves? Most commonly, we see alcohol. That's a big one, right? And I feel like alcohol is pretty accessible if you can get together a few dollars and it's legal, right? People don't look down on it as much. If I walk into a room and I say to someone, hey, let me have a drink, it's probably normal. Whereas if I walk into a room of my friends and family and say, hey, does anyone have a bag of heroin? They might look at me like, what? Are you kidding me? Like, you're doing that, or don't talk about that in front of people, right? Different stigma, sometimes with different substances. Also, a lot of cocaine and opiate use. We know the opiate epidemic is still alive and well and has been exacerbated by the pandemic. So we see a lot of opiates, methamphetamine and marijuana use. Sometimes, you know, marijuana use is one that as a clinician, you have to figure out how you feel about it. Are you a harm reduction program? Are you an abstinence-based program? Does this person qualify for medical marijuana? And can you help them get there so that they're not using it off the street, but anywhere mixed with who knows what, right? So you really have to kind of take marijuana and look at the person's context that they're using it in, because it may be okay and it may actually be helpful and not necessarily detrimental. And a lot of people, particularly younger people in their 20s that come through our program, are also using over-the-counter medications, which always reminds me that I'm old, because I'm like, what? This is a thing now? I don't ever remember people talking about this. They're specifically using the medications that have DXM as an ingredient. So think about Mucinex, Sudafed, cough syrup, right? They're using it and they feel kind of a trippy feeling is how they describe it. And it definitely numbs them. On the flip side, if you already have hallucinations, delusions, taking a medication with DXM and abusing it, you're not just taking the suggested dose, you're taking 1, 2, 3, 4 packets at a time, definitely will exacerbate those symptoms. So to me, that does not sound like fun, you know, to have a high that's doing that on purpose. But a lot of younger people especially seem to be doing this. We actually had someone that I worked with fairly recently stealing from pharmacies and then almost overdosing on these things. So it's very, very serious in younger populations. So I mentioned I would talk about prevalence rates, and I want to start with adults, just in general. So the National Institute on Drug Abuse funds research every 2 to 3 years to get a feel for what the prevalence rates are for mental health disorders in general, substance use disorders in general, and co-occurring disorders. So the most recent research that's been published was in 2017. I believe I read that 2019's data has been held up due to COVID, of course, and like say it with me, right? We all know what has been delaying everything, right, over the past year and a half. So hopefully those stats will come out soon. But the most recent I had to offer you is from 2017, and Han and colleagues found that of all of the people that they collected data from, 7.7 million of them were affected by total disorders. And they're trying to canvass everyone United States wide. And they will try to collect data from just people in general, like online recruiting through medical providers, through mental health providers, substance use providers. They canvass everywhere they can to be able to get data from this. So it's a pretty thorough data collection. They found that in general, 42.1 million people reported being affected by mental health disorders. And they didn't have to really be diagnosed because they have a section for, is it actually diagnosed? And then, no, you know, like I've just felt this and I think I would qualify for a mental health diagnosis. And of those 42.1 million, they found 18.2% also would qualify for substance use disorder diagnoses. So that's a pretty big number, right? And maybe you're not surprised. You've been in the field for a while like I have, and that kind of represents what you've seen, kind of represents what I've seen. They also found 20.3 million are affected by substance use disorders, and 37.9% of that 20.3 million would qualify for a mental health disorder diagnosis. So extremely prevalent, right? I know on my team, sometimes we joke about the intensity of COD treatment, and we wish those numbers weren't as huge as they were, right? So that's why we're working to help people who are challenged with these different disorders. I wanted to also mention prevalence rates in children and adolescents, just in case some people are here working with those populations. And there is a youth risk behavior survey that happens every year. So last year, obviously, COVID again, right? I feel like I'll be using that justification for so many years after this because of the impact it made worldwide. But the 2019 results, again, given out by schools, doctors, mental health, families, you know, you might actually get this in the mail. They still canvass that way, which as a researcher sounds interesting to me. I didn't know people still got paper mail, right? But I guess that's a way to make someone pay attention. And they've estimated that rates of total disorders in children and adolescents is between 60 and 75%. And to me, that was such a huge number. Again, I don't work with this population. Maybe that's what people have experienced in that field. But to me, that was alarming that our young people are really, really struggling with total disorders. And what they found is that youth who have been diagnosed with major depressive episodes are twice as likely to use alcohol or other illicit drugs. And I vaguely remember being a teenager, but that was a pretty long time ago for me. And I remember it was pretty terrible. I would not want to have to go back to that time, right? Because everything's changing. Your friends group is changing, your body's changing, life is changing everywhere. And it's normal to feel ups and downs. But sometimes it's more than those natural ups and downs. It's an actual major depressive episode. And I think now I have a niece who's 14, a nephew who'll be 16, and just the bullying that kids in their school put up with, all of these other things seem to really be correlated with mental health issues. So I would never want to be a teenager again in 2021. It seems definitely hard. Interestingly, they also noted that 29% of kids would never use any alcohol or drugs before experiencing a major depressive episode ended up using. So even kids who we think wouldn't touch the stuff may end up doing so if they have a major depressive episode. So again, excuse me, that may be, not news to some of you working with those populations, but for me, that was pretty alarming. Thankfully, my niece tells me she wants to be a mental health and addiction counselor. So I guess the world can continue. She can help us, with that issue as she gets older and educated and listens to all of that fun stuff. Um, so also, I wanted to throw in there too, I don't have a slide for it, but just in case you work with the elderly populations, right? Because I know that they're also an area of concern. It tends to vary by population, but surveys through the National Institute of Drug Abuse have said that between 7 and 38% of people have psychiatric disorders as they're elderly. And of that 7 to 38%, 21% to 66% have a substance use disorder. So that's the co-occurring right there, 21% to 66%. And the most common combination in the elderly is depression and alcohol. So some of you may already know that. I thought that was interesting. I do see a lot of that just, with my dad who passed away recently, but he was 89 and went to a senior center every day. And he would talk to me about a lot of people who he thought might have been depressed. And he would tell me, I know nothing about depression, but I'm pretty sure that's it. So it had to be pretty strong symptoms or strong changes in behavior that he was seeing. So that did not surprise me as much, and that's just based on hearsay, right, from my informal data collector of my dad, right? It was interesting how he was tuned into it. Usually he was oblivious, and he knew I would tell him that. So I don't feel bad saying that to you guys. He knew. That was our joke. He was oblivious, so it must have been bad. So in terms of getting people with co-occurring disorders to actually get treatment, it's no surprise that research consistently shows that there are a lot of gaps in treatment need, service need, and the actual care that people receive. So back to the National Institute of Drug Abuse and Mental Health Services, which SAMHSA, most of you have probably heard of, Han and colleagues found that, strictly speaking, with people in the co-occurring disorders population, 52.5% receive no treatment for mental health or substance use. So that was pretty sad when I read that. I've always specialized in this area, so I guess that's why it feels to me that lots of people are getting treatment, but really, across the United States, it's as many as I might think. 34.5% receive only mental health treatment, 9.1% receive both, and 3.9% receive only substance use treatment, which is really sad because when you mix substances in, it becomes even more dangerous, right? Any condition that we may have is usually made worse when we add substances in the mix. So you might be wondering, it's 2021, why don't people go to treatment, right? So think about pre-pandemic, right? Because I know there's lots of research happening and still going on in terms of, how the pandemic affected this area. But prior to the pandemic, stigma was still a huge thing. Stigma regarding mental health and substance use. And I would like to think that in 20 years of being in the field, that got better, but I'm not really sure that it has in our communities. I feel like, though, younger people, like I said, my niece and nephew, are more aware of it than I ever was as a teenager. So I hope that that's helping somewhere they're getting the education, whether it's in school or, families or whatever. So hopefully that helps to continue. I remember one day like being sad, and my niece said to me, it's okay to be sad. You don't have to be shy about it. You can tell us. So I was like, hey, all right, that's fabulous, that feelings are okay, whether they're, up, down, all across the map, that made me happy. I'm like, you listened to something I said, which is nice. There also continue to be gaps in awareness for the actual person with co-occurring disorders. They may not know what the heck is happening. Maybe they know they're using substances and they attribute everything else they're going through to the substance use. And when they stop using substances, they're like, oh no, these symptoms are still happening. What does that mean? What is that about? And maybe they're shy, maybe they're afraid to actually get information or try treatment, talk to a doctor, talk to a family member. So that's still an issue, you know, self-awareness. Also some provider and gaps in knowledge within the field, and that actually creates a pretty damaging cycle, and I outlined that cycle for you on the next slide, so I don't want you to think I'm glossing over that one. And of course, systematic barriers showed up in the research. Labor shortages in certain fields, right? I know a lot of people are going through that now, and professional burnout. Working in mental health, working in substance use, working in co-occurring disorders can take a toll if you don't engage in a lot of self-care. So a lot of people do go through burnout, and that might, you know, go along with the labor shortages, people leaving the field that we hadn't planned on leaving, right? If there's a mass exodus from the field, we're in trouble. You know, we have a lot of people to serve, so we're hoping that does not happen. But I wanted to talk a little bit more about that cycle. So this lack of awareness is not just, you know, for the person, it could also be for the providers. Now, I think the educational curriculums, I know the ones I'm a part of, actually teach a lot about co-occurring disorders. But early on when I was starting in the field, we didn't really talk much about it, like it was mentioned. And even though I had a double major in psychology and forensic psychology, it still wasn't a huge part of our curriculum. And now, as I'm teaching classes, I have the ability to incorporate it in, master's programs incorporated in, right? So this lack of awareness from a provider perspective should be decreasing. And that's what Han is waiting to see within his current research study is this actually getting better? Lack of training, I feel like that's something that people just don't know about them, whether it's law enforcement populations, medical populations, addiction populations. A lot of times you're not trained to understand them. When I was doing law enforcement, we didn't really consider mental health, and we see that changing today, thankfully. So lack of training might be part of it. I know also when in the past programs would say, oh, if you're actively using, we're a mental health program, don't come back until you have some sobriety time. Or addictions would say, you know, you've been abstinent for a while, it seems like your mental health issues might be flaring up, go to them first and come back to us when you need us. And that was really not always the best way to handle things. So thankfully we now know best practice is not necessarily to do that. And I feel like this lack of training is probably getting better than it was initially. And lack of assessment, I know sometimes people are really like focused in the assessment, which is good. I'm not telling you not to be focused, but you don't want to be overly focused. Like I've done addiction treatment forever. I have to still assess for mental health, right? I may not be an LMHC, I may not be an LCSW or have a specialty in that, but I still have a duty to my client to assess for it, and vice versa. If I'm a mental health counselor, I need to at least screen for substance use. I don't have to be an expert, don't have to know how to treat it, but I should really just at least be able to screen for it. And hopefully diagnose it, right? Because lack of diagnosis is something that prevents people from getting treatment. If you don't have a diagnosis, people are going to say, why are you here, right? What do you need to do? So I feel like now in 2021, this traditional cycle that research has shown us seems to be getting better, but there's also room for improvement, right? We're always trying to improve best practices and evidence-based interventions. So I guess that's why we always need researchers to continue looking into some of these things. So to further prevent this cycle from happening, I think that providers are a big key piece of this. And we have to have, especially newer providers, understand why screening is important. And we'll talk about that more shortly. And we also should educate our clients on co-occurring disorders and really just normalize this so that it removes the stigma. So I know a lot of times in our program at TSI, people are really hesitant to acknowledge and accept that they have a mental health disorder. And my co-occurring disorder specialist, myself, his assistant, all of the counselors in our team, try to really work with them to understand the relationship between mental health and substance use and normalize that many people have, both of these disorders at the same time, just to help them move toward acceptance. I'm not saying that we have a magic wand and everybody gets it and accepts it, but they definitely will at least think about it. And that's all we're asking them to do. And hopefully that will remove the stigma. I've actually had clients tell me, and for various reasons, it tends to be male clients, say to me, oh, yeah, I can be an alcoholic, but I can't be depressed. I can't tell my family I'm depressed. And I'd be like, really? You can tell them you're an alcoholic? I don't know if I'd want people to know that, if that was something that I was doing. And I may feel my own shame and stigma about it, but, he's okay with that. So having a therapeutic confrontation, like, okay, tell me why that's easier, or tell me what your family thinks about mental health, right? To kind of break down some of those barriers and to help move that person toward acknowledgement or acceptance. Learning how to assess people, and we'll talk about that in a couple of slides. And in the training in October, I'll be talking to you guys about some specific techniques and some specific best practices that you can use when you assess. We also should learn how to recognize symptoms of both mental health disorders and substance use disorders. So in my program a lot, in our case conferences, we help each other when we review cases to see if someone's struggling with active addiction or if they're struggling with mental health symptoms at that time, or if it's a combination of both. This helps us talk to them about their options. So a lot of times people will be actively using, missing appointments, maybe they're, skipping out if they have to do a tox at outpatient, or they're avoiding outpatient altogether, any of that stuff. We may want to sit down with them and say, what's happening? Are you using? Or, have you been having cravings, right? We don't want to be punitive and just come at them and attack. We want to say, how have your cravings been lately? Have you noticed them happening more often, less often, about the same, right? Just gently kind of assess those things to help them recognize symptoms of addiction and mental health disorders so that we can help them address what's happening. And then always educate clients, right? I'm a counselor educator and will be a research and teaching psychologist when I'm done with my PhD. So educating is always my soapbox, teaching them as much as we can to empower them, right, to advocate for themselves and, get to where they want to be and get through their challenges. So when we assess these disorders, if you've never done this before, we should try to be as holistic as we can. And being really comprehensive and holistic means that there's a lot of complexity to your assessment. So it usually feels overwhelming to the client. And I'll be honest, probably overwhelming to me as a clinician, right? Like they're asking all these questions and they're maybe remembering stuff they hadn't thought about in a long time. So it should be pretty overwhelming. So I know in our program, we don't assess to diagnose. People come into our program already with a diagnosis, but we assess the status of mental health and assess the status of substance use. And we do that in an ongoing manner so that it's not just one huge assessment appointment. We're sitting there for 90 minutes or however long getting someone's life story. So if you could break it up a little bit, that's helpful. Depending on the context you work in, you may not be able to do that. So you have to do what you can. But to be holistic, we want to look at, mental health history, current symptoms, substance use history, current systems, lethality risk, physical health, any major stuff happening in the history, talk about family, maybe probe for trauma history. They may be open with you right away, they may not. So, in the assessment, you may just want to note how they appear when you ask those questions, if they're defensive, guarded, or maybe they're just very, very sad and they cry when you ask the questions and they don't answer them. So just to give you a feel for maybe there's something there, maybe we'll never touch it, but you know it's there and you can acknowledge that it's there. Also, you should include what they're good at, what their strengths are, who their supports are, what their hobbies are, or maybe if they worked in the past and did they like it, or what was their favorite type of work to do, or what hobbies were they interested in when they were at their healthiest, stuff like that. Cultural needs and any readiness for change. So we do want to know where they stand, right? So I know I usually use the stages of change for Chasta and DeFomenti, and I'll, describe the different parts to them and ask them like where they are in that, change progression. And it's hilarious that everyone always tells me they're in maintenance. And I have to be like, okay, show me how you're in maintenance. Talk to me about what shows you that you're in the maintenance phase. And then sometimes they'll say, oh, yeah, I think maybe I'm not in maintenance. They're trying to, I'm like, what does maintenance mean to you? Right. So that's interesting to see where they are. It's always best to meet them where they're at, right? To get them where they want to be. Also know that in these assessments, it's really difficult to differentiate the diagnoses, especially if there is current substance use, right? So like someone actively using cocaine may present as very high energy, rapid speech. I might mistake that for mania of bipolar. So I typically will ask someone if they can tell me when their last state of use was before I start doing any of this stuff, because I just want to know. Like, if it was last night, maybe I need to ask different questions, right? If it was 3 months ago, maybe I should say, all right, this might not be due to substance use, might be post-acute withdrawal syndrome, but probably not immediate substance use. So definitely ask as many questions. I always say, don't be afraid to ask the questions. The worst they can do is not answer you, right? Like get mad at you, maybe be silent, give you the silent treatment for the rest of the session. But over time, we get used to those behaviors and defenses and learn how to manage them, right? Also, in our program, in my advisories and just in our team building and in our case reviews that we do, we talk a lot about how we can overcome some of the challenges that are out there. So the biggest thing that, I've seen in my experience, and that's backed up by a lot of research, is that the relationship is the most important thing, the most important tool that we have. So you want to try to work on engagement and build a therapeutic alliance with your client however you can in an appropriate manner. It'll be like go out to dinner and eat tacos every night and talk about your family, like none of that stuff, but work on engaging however you can. So in my program, people meet with one primary counselor, they meet with my coworker and disorder specialist, but they know the entire team and they can talk to anyone about anything that they need to. And this is because our team actively works on engagement from the time the person moves in. So if someone moves into our program, everybody that's available helps them with their belongings. And everyone introduces themselves, checks in with them and says, hey, are you from Buffalo? Hey, have you ever lived on the Elmwood Strip? Or how are you feeling about living here? Right? Like we just ask them questions. it's the first time meeting someone. So we'll make small talk, right? We'll chat about stuff. My total hearing disorder specialist loves sports. So he'll say, hey, do you watch any sports? What's your favorite team? He can talk to people about anything, I'm telling you. Like any subject under the sun, he's brilliant. So he can engage people usually just like that because of his personality and because of his people skills, really. So we work together on engagement. We try to build that alliance through the smallest things that we can so that they know they can come and talk to us, right? A lot of times we have stuff in our offices, right? I have pop figurines. Like if you have a kid, you might know of Funko Pops. And I have like different ones on my uh, shelf behind me, like the Notorious B.I.G. or Prince Harry and Meghan from their wedding, you know, like just random ones, Britney Spears, everywhere, all of those, right? And sometimes that's the silliest thing in my office, but it engages a lot of people. And so they'll be like, oh my gosh, you know the Notorious B.I.G.? I'm like, yeah, shocking, right? I like, you know, love to hear all different kinds of music or, you know, just small things. And we all try to do that. So they know who likes video games, who they can ask video game questions to, who loves music, who loves sports, right? So it just helps them to feel open with us. Um, it also helps to include the client in the process whenever you can, if it's possible and if it's reasonable, right? There's not going to be times you can offer them to be a part of the process all of the time. Like if you're in a provider meeting trying to coordinate care, maybe they're there, maybe sometimes they aren't. You plan, you know, what's going to happen and then include them in afterwards. It just helps them to feel a part of the process. And I often use my experiences with cancer as a parallel process to the residents in my program because if I don't know what's happening, if my team doesn't communicate with me, I feel anxious. I feel really afraid, right? There's all kinds of feelings that can be overwhelming. But if they call me and say, hey, this is the next step, or this is when your appointment is, this is what they're going to go over with you, it's a little bit less scary. So we try to do the same thing and inform them when we can. We explain to them why we're doing what we're doing, screening, assessment, paperwork, anything that we have to do, we explain to them why we need it. And usually we will start with a screening instead of an assessment. We have their information. Our intake department does a beautiful job of putting together a very thorough intake assessment for us. So we have that advantage that a lot of people get of having someone come in the door with an assessment. But the assessment kind of tells us what to look for in the screening. So if it's, you know, depression symptoms, if it's triggers for substance use or any of that stuff, that kind of is a springboard for us. You may not have that. Just sitting down with a client and saying, what brings you in today, hopefully will trigger you what you might want to screen for. But sometimes that just takes practice. We usually do it really informally. We want to be sure it's not punitive, right? So we don't want to have a phone call from outpatient saying so-and-so tested positive for fentanyl. And I don't want to march up to so-and-so's apartment and say, hey, look, now you have to come down and do a test because you tested positive in outpatient. Now I have to screen you for fentanyl. You never reported using that before. That definitely will make someone defensive. It will make them shut down. So instead, for us, you know, what we would usually do is when that person comes downstairs, they always come downstairs to our offices to maybe say, hey, how have you been feeling? You know, have you been eating okay? How's your medical situation? How's your mental health? Have you been taking your meds? You know, how's outpatient been going? And then, you know, I'm a little bit concerned. I talked to outpatient and they mentioned they taxed you recently and it came back positive for fentanyl. You know, like, how often do you use that, do you think? Or how many times have you used that in your life, do you think? Right? Like just a very informal conversation instead of a tool that you have to use. If your agency requires you to use a validated or evidence-based tool for formal screening, they should have that available to you. and there are a lot of them, OMH website, Oasis website, New York State Clinical Record Initiative, right? There are examples of assessments, templates for you to use, actual tools that you can use to do that. So if you're not sure how to do that, supervisors should know, other people maybe that you get supervision from, peers may know, reach out to people in your agency. My contact information is at the end of the presentation. Reach out to me, my COD specialist. There are ways to find them. But your agency probably picked certain ones, so definitely use what they ask you to use, right? What works for you. In our program, we have a little bit of leeway. I always run it by my program manager. Hey, this is what we're going to do. If she says, okay, give it a try, we will. If she says, you know, maybe this one would be a little bit better, we'll use that one, right? So just have a conversation with the people that give you supervision about it. And probably most importantly, sometimes we tend to think of assessment as a one point in time thing, but especially with COD clients, the assessment should be ongoing. The entire time that I know them, I'm assessing them. And I try to do it with them. I don't just sit back, I mean, I always sit back and overthink things, right? But in this instance, I don't want to do that. I don't want to overdiagnose or give people more issues. So instead, I might sit back with the client and say, hey, we started working together 3 months ago. What do you remember from how you felt 3 months ago, or what you were experiencing 3 months ago? And how do you think you feel today? What's changed? Or what you want to work on now? What maybe has increased, you know, that you've realized is a bigger challenge than you thought it would be, right? So always doing for this. And we do that when we do treatment plans, right? We have to review those plans. In our program, we review our plans every 3 months with people. They're aware and reminded of them every time they sit down with their counselors for a meeting. So we're always assessing, and it kind of teaches them to always assess too, right? And do like a self-inventory of how am I today? Or wow, I really came a long way, right? And a lot of times in our groups that we offer, we'll have people kind of go around the room and identify changes they've seen in other people. And that's an activity that my former supervisor used to do, and it intimidated me because I'm like, really? We didn't ask them what they think about each other, what they live together, right? They're together all the time. But really, they dug deep and gave some really, really effective and valuable feedback to each other. So we try to do that with them every now and then. And seeing someone, hearing people say positive stuff about them is a really neat thing as a clinician, you know, because it's not just you giving that to them, or their family or whoever they're closest to. It's someone that's just been in this therapeutic group with them for a long time, or in this, you know, residential rehabilitation program for a while. And I think sometimes it sticks more and it might mean more. So you can be creative with that ongoing assessment. It doesn't have to just be one of those things. Um, so I also wanted to, I definitely yak a lot, as you guys can see. Now you know how my per students feel, right? Like, have a lot to say. So I wanted just to touch on best practices for providing services for clients with COD diagnoses. So remember to treat both disorders at the same time. Don't forget that both disorders might be active for that person. So I always make sure I check in with clients on mental health and substance use. I often have clients use a symptom chart. And if you're not sure what that is, if you haven't heard that before, you basically have a calendar and they mark down whatever symptoms they have, on what days and maybe the duration of the symptoms. They could do one for mental health, one for their substance use disorder. I have some people who do it all on one. I've even had people do a huge one that they color code and they make a key for what they really get into it. So, you know, but it really depends on the person that you work with. And that's one of the things I'll be showing you in the next, you know, training later in October. So you get a visual of that. But always address both at the same time. Try not to put one on the back burner unless that person has, the other condition really, really giving them challenges, right? Sometimes people's use may become out of control, and we have to coordinate with outpatient providers or whoever. Maybe we are the outpatient provider. We have to get them to a higher level of care to address what they need to address. That's fine. We want to do that. We want to get them where they need to be. So always just be mindful of both disorders. We need to also make sure that services are person-centered and comprehensive. So always try to give as many services as that person can qualify for in a way that's helpful to them, right? Don't overwhelm them. If the first day my doctors told me 12 years ago all of the things I would have to do for the next 12 years to fight cancer, I would have been like, yep, nope, I'm out. See you later. It's not going to happen. So we don't want to overwhelm them with the services, but we want to make sure that we're looking at everything holistically, right, to offer them the best chance for success. Also, it helps if services and staff are trauma informed, right? We take the stance that everyone we meet has encountered trauma in their life in some way. So we try to be mindful of the language we use with clients, try to set up a safe space for them to talk, maybe quiet, low light, comfortable type of space. I know in our office specifically, it's really tempting to yell out to each other, right? Instead of getting up and walking to someone's office or like picking up the phone or emailing. So we've tried to really cut back on doing that. We make sure we email, we have Microsoft Teams, we make sure that we're, doing it communication in that way, because we don't know if a loud environment of people yelling may trigger one of our people that we work with. So we just try to really be mindful of that and set up a safe environment. Try to incorporate culture wherever we can. Talk to the clients about their culture, how we could change our services or modify them to help honor their culture. Again, that's being person-centered, right, for everyone that comes in. And definitely make sure that services are still offered at all levels of care and at all courses of the disease. So highs, lows, inpatient, back to outpatient, we should still be coordinating, right? Making sure the person got there before we close them out or hold their bed or whatever our agency policy is. Still offer those services, right? We don't want them to lose their linkages since it's so hard to get them there to begin with, right? And of course, I can end with a mini plug for our program at Transitional Services. We have the program I'm at right now is the co-occurring disorders residential rehabilitation program, which is a level 2 congregate care program. It is transitional living on the strip, and we call it TLOTS for short because it's a lot to spit out, especially if it's hard for you to speak, right? So it's a lot easier for me to say TLOTS. We focus on helping people increase daily living skills and relearn those skills, apply coping strategies, integrate in the community, and we are actively trying to prevent homelessness. Without living in our program, the residents we have would be homeless, so we don't want them to be. Our program provides apartment living. We offer medication management, assessment of the current status of diagnoses, peer support groups. We have licensed staff and unlicensed staff working. We have New York State certified peer counselors with us, advocates with us. We offer social recreational activities. Our coordinator picks awesome stuff. They decide what they want to do in our tenant forum. He takes them to Bills games, to Sabres games, to Bandits games, grocery shopping. If they have to do budgeting, he helps them with that. They do game nights sometimes, which are fun. They do potlucks, you name it. They want to do it. He figures out a way to make it happen. So that helps them relearn social skills, right, in a positive environment. And mainly we're concerned about facilitating residents' recovery identity formation, right? They have to figure out who they are now that they have the skills to manage mental health and substance use. What do they want to do to have the best quality of life that they identify for themselves? So now that I've talked to you off, in conclusion, we know children disorders are complex and that with effective support, clients can recover with both disorders that they experience. And clinicians always develop skills with experience. Don't be intimidated to work with this population. It's really rewarding, challenging, but the rewards in my experience have outweighed those challenges. So I know the presentation will be posted. I put my contact information on here in case you have any questions or comments. My co-occurring disorder specialist, Scott Scalia, has also offered to share ideas, share interventions, any creative ideas that you guys use. He would love to be a part of exchanging it. So definitely feel free to reach out to us. And thank you everyone for attending. I appreciate the opportunity.
Amy, I think you might be muted. There you go.
Jillian, thank you so much. That was awesome.
Thank you. Yeah, it was my pleasure.
Okay. It was wonderful. So as Jillian mentioned, she will be back in October to go into more detail on co-occurring disorders. So please watch for the registration and notice for that. We'd love to have you back. I did post the information, the link for the evaluation in the chat box, and ask that you take a moment to complete that for us. The presentation will be posted on our webpage, erie.gov/mental health after the session. That will be the presentation and the recording. The link to register for the August session is also in the chat box, and that's adapting to our new normal with Esther Call and Ayana Lau from Child and Family Services. If you're interested in being a presenter, please let me know. We're still looking for folks for September, and I think we're scheduled through till January. There won't be a session in December. We're going to take December off because it's also the weekend or the week between Christmas and New Year's, which is a better time to be doing other things. But this was a wonderful presentation. Thank you, Jillian.
Thank you.
Very engaging,
Thank
very
you. I appreciate it.
informative. I don't know if anyone had any other questions. There was a lot of information.
Yes. Yeah,
and
definitely.
Really, it was wonderful.
Thanks.
Wonderful.
I was trying to make it not so packed, but there's really no way not to. So I apologize for that. Thankfully you have the slides
No,
to review later on.
that's why we're here.
Yeah, right.
We all want to learn, so thank you.
Yeah.
I don't see any comments or questions.
No.
So you will get approximately 1 minute and 30 seconds back in your day. Please do the evaluation. Hope to see you at future sessions and have a wonderful day.
Thank you.
Thank you, Jillian.
Yeah, send you both. I appreciate the opportunity.
This was fun.
That was great. Thank you.
Good. Yeah, thank you.